Okay, in this second piece, we're going to talk about measuring and estimating the GFR. So in the first video about CKD, we talked about how we define CKD, and obviously we care about the GFR, and CKD is defined by, partially at least, defined by a low GFR. And so we need to come up with a really excellent way to measure the GFR directly, or at least estimate the GFR, because that's how we educate patients and that's how we make clinical decisions. So remember, glomerular filtration is happening on a microscopic level, so there's no way we can really measure it or estimate it using physical exam or imaging test. We actually have to administer some substance, like an exogenous marker, and then do a little math to actually figure out the GFR. And so inulin is an inert substance that is an excellent exogenous marker that we can use to measure the GFR. So here's why it works. Inulin is selectively filtered by the glomerulus. It's not excreted by any other system, so it's filtered by the glomerulus. And most importantly, it is not reabsorbed by the tubule, so that does not occur. It's not actively secreted from the plasma into the tubule. It's only filtered here at the glomerulus. So all the inulin that ends up in the urine came from the glomerulus. So essentially we can determine the urinary excretion, the urinary clearance of inulin, and that will help us determine the GFR. And we can use this equation. The GFR essentially equals the urinary concentration of inulin times the urinary volume divided by the plasma concentration of inulin. And this is how we can measure GFR. However, inulin is rarely used. It's expensive and it's inconvenient for the patient. Think about it, to get a pure urinary collection to be as accurate as possible, you'd have to place a bladder catheter and obtain all the urine that way, and that has risks. So nowadays we do have other markers, and so iohexol is one, radiolabeled iothalamate, radiolabeled DTPA, and radiolabeled EDTA, or other exogenous markers that we use nowadays to actually measure the GFR. And instead of calculating a urinary clearance, we can calculate the clearance from plasma using blood samples. So these are the markers that are used nowadays. But think about all the patients with CKD and all the patients whom you want to have a good guess, or you want to know the GFR. We don't order these measurement tests on every single patient who has CKD. In fact, nowadays, most of the people who get GFR actually measured are patients who are being evaluated for live donor surgery, because in that case, we actually are interested in whether they could lose a kidney or not, and we actually need to know the GFR. But for the vast majority of patients, we don't measure the GFR. Instead, we estimate it using endogenous markers. So let's talk about that. So now it's time to talk about creatinine. And so creatinine is an endogenous marker that we use to estimate the GFR. So creatinine is produced by muscle. So it's actually a byproduct of muscle metabolism, and it's usually produced at a fairly constant rate. And the reason we use it is that it is freely filtered by the glomerulus. Okay, so whatever is produced, filtered by the glomerulus, goes into the urine and excreted by in the urine. However, about 15% of it is actually secreted, so actively secreted by the proximal tubule in the kidneys as well. So it's not perfect. So a perfect marker would only be filtered, not reabsorbed, not secreted, but a little bit of creatinine is actually secreted by the tubules, and then it's excreted in the urine. Also, it's worth noting that excessive meat intake or protein supplementation can also lead to increased creatinine production, which will result in a need for greater creatinine excretion in the kidneys. So the way we use an endogenous marker like creatinine is such that when the GFR goes down, the serum creatinine will increase. So what actually happens is that when the GFR declines, the urinary creatinine excretion declines. That causes the creatinine to increase, but what happens over time is that actually a new steady state is reached, such that muscle production of creatinine equals the urinary excretion. So the urinary excretion will actually pick back up to match production, but sort of at the cost of a higher serum creatinine. And so we use that serum creatinine to try and estimate the GFR, but remember, muscle mass also determines the creatinine, and so we have to try and get around that through our estimating equations. So these estimating equations, such as MDRD and CKD-EPI, essentially they use the serum creatinine to help estimate the GFR, but there's other variables in each equation that are trying to take into account for the variability in and the creatinine that's produced by muscle mass. And so if you look at these equations, there's other variables like age, sex, ethnicity, and body size as sort of imperfect measures of muscle mass and the variation across different people. So every lab nowadays is at least automatically reporting the estimated GFR based on the serum creatinine, but it is up to you to sort of look at that and see if it makes sense based on the patient you're seeing. You may also hear someone speak about creatinine clearance, or you may even measure creatinine clearance from a 24-hour urine, but keep in mind the creatinine clearance will exceed the GFR. So it's greater than GFR because of tubular secretion, which we mentioned earlier. So 15% of creatinine excretion occurs through tubular secretion. But remember, I mean, for the purposes of understanding the GFR, we only care about glomerular filtration. So this tubular secretion piece is sort of a confounding variable. So as long as this is occurring, the creatinine clearance, the total amount of creatinine in the urine, will actually exceed our GFR. Conversely, what about any medications or drugs that would actually block the tubular secretion of creatinine? So this happens from time to time clinically, and I want you to be able to recognize it. So another drug could be co-administered that really needs to use this organic cation transporter, and if it's competing with creatinine, it could block it, and then creatinine is no longer being secreted by the tubules, and glomerular filtration is the only route creatinine could be secreted. What happens in that situation is that creatinine clearance actually goes down a little bit, and the serum creatinine may rise, but the GFR stays the exact same. And so this is a situation where you don't want to be duped by a false positive, essentially, rise in the serum creatinine. And so some of the drugs that are known to do this include trimethoprim, cimetidine, fenofibrate, and pyrimethamine. So some of those drugs aren't used as often anymore, but trimethoprim, which is a component of trimethoprim sulfamethoxazole, is used a lot as an antibiotic. So this can cause this rise in the serum creatinine that actually does not reflect a change in GFR. Okay, next I want you to start thinking about the muscle mass of your patient. Remember, the serum creatinine is going to be determined by a number of things, but most importantly GFR, but also muscle mass, because it's just a byproduct of muscle metabolism. So what about patients who have widely variable muscle mass, and how would that correspond to the eGFR? Okay, so let's consider this character over here. So this figure is very thin, has very low muscle mass, and let's just consider that this person represents maybe a patient with a muscle wasting disease, maybe a patient who's had a limb amputation, or maybe malnourished due to malignancy or some other chronic illness. So in this kind of a patient, think about it, with less muscle mass, they're going to be producing less creatinine. And so using an estimating equation, the eGFR you get from that is probably going to overestimate their actual GFR. So the eGFR is probably going to be higher than the true GFR for this patient with a very low muscle mass, outside of the range of what you're seeing. Certainly outside of the range of the kind of patients who were used for these estimating equations when they were validated. Okay, now what about this figure over here on the right? So this person is very, very muscular, perhaps a bodybuilder. And so in this kind of a patient, the serum creatinine may be elevated. It may be higher than what we'd see in a person of the same age, same gender, same race. And so using an estimating equation would probably underestimate the GFR. So the eGFR is going to be lower than the true GFR. And so a patient in this condition may be diagnosed with chronic kidney disease when they don't have chronic kidney disease. Whereas this patient, the frail patient with very low muscle mass, they may be, you may think their GFR is better than it actually is. And so both of these situations are important, right? The muscular patient may get diagnosed with something he or she does not have. You may underdose a medication in this patient. However, the frail patient, we may be missing a lot of chronic kidney disease, or we may be not adjusting medications accordingly. So, the equations work best for this patient, maybe the patient in the middle who has normal body mass, but they are less accurate for patients who fall on either extremes of muscle mass. So in my field, in internal medicine and nephrology, we probably see more patients who are of low muscle mass than the bodybuilders, perhaps. It's still possible we could see a bodybuilder every now and then, but we tend to see patients who are frail with low muscle mass. And this is something to really consider. The estimated GFR is really just an estimate. It's a best guess, but if you're on the fence about what you think the GFR actually is, kind of look at the patient, consider the muscle mass, and then you can fudge the GFR up or down based on that. And so for the frail patient with low muscle mass, it's okay to sort of fudge the GFR down to find out what the estimate really is. Remember, of course, you could always order a measured GFR on either of these patients to actually determine that. But they are a little more costly and do involve a little more work. So obviously creatinine has some issues with it. I mean, it varies according to muscle mass and diet. So there are a lot of variables that we can't adequately assess. But there is another endogenous marker called cystatin C. So this is a low molecular weight protein that's produced by all nucleated cells. And so therefore it doesn't vary according to muscle mass or diet. And it does vary according to age and gender. And there are a number of things that increase the cystatin C concentration aside from a decrease in the GFR. So things like corticosteroids, inflammation, smoking, and hyperthyroidism can affect cystatin C concentration. So the concept is the same in that you can take a serum cystatin C concentration, plug it into an estimating equation, and get an estimate of the GFR. But you could use either creatinine or cystatin C nowadays. They each have their own set of equations. Some people may even combine the eGFR from cystatin C with eGFR of creatinine to get a sort of a different kind of an estimate. So there are many ways to do this, but I'd say at least be familiar with the serum creatinine and those estimating equations, just because the testing is ubiquitous and you should be familiar with it.